Direct Connection is made by MPT to serve all of our diverse communities and is made possible by the generous support of our members. Thank you. Live from Maryland Public Television, this is Direct Connection with Jeff Salkin.
Hi, everybody. Thanks for tuning in for Direct Connection. Just ahead, finding the right kind of specialist care for older relatives. But first tonight, the dire situation in North Carolina in the aftermath of Hurricane Florence and the question of how we can be prepared for disasters like that. Joining us is Russ Strickland, Executive Director of the Maryland Emergency Management Agency. Russ, thanks for being here.
Thank you very much for the opportunity.
This rain that you just walked through in our parking lot is associated with the remnants of Florence.
Yes, it is.
Are we seeing any more than rainfall here?
We are having not only the rain, but a little bit of wind, not much wind, but we're also having some tornadoes, or tornado watches and tornado warnings.
You had one reported damage from the Cecil County area.
We did have one in Cecil County, supposedly touched down at the Fair Hill property up there.
Injuries or just damage?
No injury, just damage to the barn.
Yeah. You know, you think about hurricanes, and they talk about the butterfly effect, that these things get started with just a little ripple off the coast of Africa, and it would not have taken much for this to have hit us and not North Carolina. Are we ready for something like that?
Well, we certainly last week were getting more detailed prepared for it if it was going to make either a direct landfall on us or have a much more impact than what it did. Midweek last week, the governor declared a state of emergency. That allowed us to really kind of rev the state agencies up a little bit. They started going down through their checklist and what preparatory actions they may need to do. We had daily conference calls with our local weather service as well as the local jurisdictions, and we're starting to try to anticipate what the needs would be depending upon where the storm might hit.
This is National Emergency Preparedness Month.
Yes, it is.
Coincidentally, the peak of hurricane season. What do you want people to think about?
Well, you know, the theme for this year's National Preparedness Month is disasters happen, plan now, and learn how. Obviously, we've had a good example of a disaster. We were very lucky with this disaster that it, didn't come up the bay or come anywhere near us. But the point of the matter is that people do need to plan for it. And to learn how, simply go to any of our websites, either the Maryland Emergency Management Agency's website, any of the local jurisdictions' emergency management websites, the American Red Cross website, the FEMA website, and it'll go through a whole litany of things that people need to think about and how to prepare themselves.
I want to focus on that, what people can do if you're in a house or an apartment, different parts of the state, what you need to do. But big picture stuff, you think about the difficulties that they're having in North Carolina right now. They have all these dams that are potential hazards once they fill up to the brim, as they suddenly have. They have these manure ponds, these hog farms, big piles of manure. They have the ash from the coal-burning power plants. These things are all little disasters just waiting to happen, and the time to deal with it is obviously not the day before the hurricane gets there.
No, it's not. And that's why people really need to think about and pay attention to what the local jurisdictional folks are telling them, as well as the state folks are telling them, particularly about evacuation. If we say you need to evacuate this area, and in fact we have a new campaign, knowyourzonemd.com, where people can put their zip code in and see if they're in a hurricane-prone area, what zone they're in. So we'll announce and tell people that they need to leave that area or evacuate. They really need to do that. Staying around is not good, and you'll end up just in a very dangerous situation like the folks in North Carolina are facing today.
People don't like to be told what to do.
I know.
And there's always fear that either the media or officials are intentionally hyping something.
We will put the governor on the TV, and he will give the message that we need to evacuate these areas. He is probably one of the most trusted highest elected officials in the country today, and when he makes that suggestion or that order to evacuate, it's serious.
All right. And this is all hypothetical. There's nothing going on at the moment.
Is.
Let me remind our viewers, if you have a question about emergency management and preparedness, give us a call. We'll have the number up on the screen. You can also email your questions now. The email address, livequestions@mpt.org. So we talked about evacuation orders. The thing about whether it's dealing with weak dams or other infrastructure or stuff around the house, a bad roof, it's more difficult to spend the money to do it when the sun's shining.
It is. And that's really called mitigation. And in my world, mitigation is the center of the universe. And that's what we really need to be paying attention to, is what is it we can do before a storm hits to better mitigate the properties we're in, our lifestyle, whatever it might be, so that we're in a better situation if, in fact, and we will, have an event. If we've mitigated well, we may very well save money and time and effort in the recovery end of things if we've done some good mitigation.
Yeah, there's also flood insurance, the idea that
yes.
you can't buy it the day before the storm gets here.
No, you can't.
What's the waiting period?
I think it's like 30 days before.
All right, so
I'm not positive on that.
An event like this is a good time to maybe consult an expert on that to see if it makes sense.
And today, just because you're not in a flood zone or a floodway or flood prone area, I would still consider flood insurance. I have a personal experience of owning several different homes, and rainstorms have filled my basement. And I was nowhere in an area that should, quote unquote, normally flood. So it's well worth a couple extra dollars to have that coverage.
We think about an emergency kit for somebody's home. What do you want them to have in terms of water, food, medicine? How many days is it reasonable to stockpile?
We talk about trying to have enough food that you could self-sustain for about 72 hours, maybe 3 to 4 days. With that, basically some water, some good canned goods that you would be able to live off of. But more importantly is to check your medications and make sure you have the medications you need for an extended period of time like that. And then the other thing is a battery-powered transistor radio.
I remember those.
Yep, because you'll want to bring up, the AM station that's going to tell you what's going on and be able to hear.
Let's take a phone call. Carroll County, this is Laura. Laura, thank you for calling. Go ahead.
Yes, hi, good evening. I have a coastal property, and I do have homeowners insurance, and I have flood insurance. Is there such a thing as hurricane insurance, and if so, should I get it? Thank you.
What part of Carroll County do you have the coastal property?
Well, it's in Virginia.
I thought so. Laura, thanks very much. Get you the answer on the air. Okay. Hurricane insurance, is there such a thing?
I've not run across that before, so whether or not there would be additional coverage you could get for your property because you're living in a coastal community, that's certainly a possibility. We push very heavily for those folks to have good flood insurance.
What kind of plan makes sense for a family? So you're planning on the macro, the state level. For an individual household, like a fire escape plan. What do you want people to think about?
It's really as simple as a fire escape plan. You want everybody to get out, but you want to know where you all are going to meet, how you all are going to be able to communicate with each other, and
we'll just pick up our cell phones.
Well, hopefully that would work. But if it doesn't, what is a pre-designated place that you know that if they do an evacuation order and you can't get back to the house, are you going to your aunt's home, your uncle's home, your grandparents' home, or is there a certain location in town your family's going to meet?
What do you know about I just heard about this, the presidential texting ability that the White House can send a single text and hit every phone in America. It was about to be tested.
That's correct. Yes, it's really part of what they call either the National Alert Warning System, and then there's also what they call IPAWS, which is the Integrated Public Address Warning System, and part of that is WEA, Wireless Emergency Alerts. Every smartphone today, and you can't turn off a presidential alert, but you can turn off like Amber Alerts and things like that, but you should really keep them on. But they're going to test that, and it will be a nationwide test of it.
And it'll say it's a test so everybody doesn't.
It will do that. It will make it very clear it's a test. And then afterwards they'll survey in certain areas to see whether or not people, first of all, received the message, and two, how their reaction was.
You're in touch with authorities in North Carolina. Do we have some people there as well?
Yes, we do. We, with the Maryland National Guard, have two what they call the Helicopter Aquatic Rescue Teams, HART. So there's 2 helicopters there with National Guard personnel on board, as well as local fire rescue EMS personnel who would actually be lowered from the helicopter into whatever the situation might be to pull people out. We have the Montgomery County, what they call Maryland Task Force 1, which is an urban search and rescue team. They've been deployed, have been down there since last Thursday, and they've been very much involved. And then there's also a boat team from Howard County and a boat team from Baltimore City on the way.
Well, we hope they're all safe. Wish them all good luck.
Yes.
Russ Strickland, Maryland Emergency Management, thanks for the time.
Thank you.
Appreciate it. When we come back, what caregivers and children of older parents need to know.
Got an unused vehicle going nowhere? Donate it to the one place that can take you any place. Visit mpt.org/vehicles and support the programs you love on MPT.
The MPT app puts our programs right at your fingertips, so you can choose when to watch, what to watch, wherever you want to watch it. Download it now.
Are you turning 70 and a half this year? If so, you generally have to start spending down your retirement account. Even the minimum distribution can place you in a sticky situation. Luckily, you can now use your IRA to make tax-free gifts. Gifts up to $100,000 will never count as income, but always make a difference. That's icing on the cake.
Make your gift for this year before December 31st. Visit mpt.org/support.
This is a box that showed you a world beyond your own. It was just a box, but the world has changed, and so have we. And now the box can be almost any size or shape. And you decide what you want to explore. Anytime, any place. Break out of the box with PBS.
For our Your Health segment tonight, joining us is Dr. Anuj Bhatnagar, a geriatrician at the University of Maryland, Baltimore Washington Medical Center. Doctor, thank you for being here.
Thank you for having me, Jeff.
Tell us about the role of a geriatrician. Did I say that right?
That's correct, yeah.
Okay.
So, geriatrician is a doctor who takes care of older adults. The definition from Medicare standpoint is 65, but it's not the age in numbers. It's basically a functional age. So I have patients in my practice who are 90-year-old and playing golf, and I have also patients who are at 55 and bound to the wheelchair. So it's not about the age of numbers. It's more of a functional age.
And it's a different specialty in that you're not treating a specific disease, unless we consider old age to be a disease.
So. Geriatrics is basically advanced primary care. So you are a primary care doctor, but specialized to treat older adults.
When does it make sense to involve a geriatrician in care decisions?
So when a loved one, if you have a loved one in the family and caregivers are seeing some signs of like a decline, like problems with memory, depression, loved ones are not eating well, they're falling over and over again, and all these problems are called quality of life issues, and they're impacting your regular problems like blood pressure, diabetes. So you kind of have that coordination and see those things and take that patient to a doctor who specializes in geriatrics.
But it's not, though you may see a lot of people with dementia or Alzheimer's, it's not like a neurology practice.
That's correct.
How do you look at those conditions? Dementia, Alzheimer's, I've heard it called, old-timers disease. Same thing?
So dementia is a bigger umbrella, and Alzheimer's is part of it. So there are several kinds of dementias, and Alzheimer's is one part of it, and that's how it falls into that category.
How do you know? I mean, if you treat people in their 50s and people in their 90s, when does an individual or their family members know that it's time to maybe change the way care is being delivered?
So that's a good question, Jeff. So I always say it's not the all of a sudden drift from adult primary care to geriatrics. It's more of a transition, and that's why at our hospital clinics we call it as a midlife and beyond. So you don't have that particular age cutoff where you kind of stop here, stop seeing a doctor who you've been seeing for 30 years and start going to a geriatrician. It's more of a transition.
The professional side of the situation you describe, where there's a long-standing relationship, when does the existing provider, the internist, whoever it is, say, I need to refer you to geriatrics?
Again, a good question. So in my experience, what's happening is when a primary care doctor is facing problems solving abilities, like the time is limited in primary care practice. And older adults have several medical problems, they have several medications, they tend to see a lot of specialists in their day-to-day life. So that kind of a navigation is very difficult and challenging for an adult primary care, and that at that point they kind of come to us and say, would you like to see a patient, or they refer those patients to existing old age practitioners.
What types of conditions do you most often see?
I would say most important condition is polypharmacy, which you are taking if you're taking more than 5 prescription medications, which is very common. Then dementia is extremely common. Older adults do suffer from depression a lot, and weight loss, recurrent falls. They have sleeping problems. Those kind of conditions they come into picture.
How often do you see depression?
Depression is very common. It's because of the dementia, it's overlaps, so it's very difficult to tweak the real signs of depression in just population. But you have to be very cautious in how you ask those questions, because older adults usually have financial problems, social isolation. Most of them have lost their spouses by this time. They have their issues with driving. The keys has been taken away. So all these things you have to look at. It's not the telltale signs of depression as you see in younger population. It's more atypical.
Let me remind our viewers, if you have a question about geriatric medicine, any of the components of it, give us a call. Number is on the screen. You can also email. The email address is livequestions@mpt.org. When treating depression in an older population, is it different in terms of medication, talk therapy? What do you recommend?
So we don't jump into starting medication. Depending on there's a scale that we use. It's called Patient Health Questionnaire Scale, and depending on that, I always talk to the older adults and say, would you like to speak with somebody about this? And most of them would like to speak to somebody about it, and that person is a psychologist. I don't bring that word psychologist because they think they have some craziness going on, but it's important. Some people, it depends on how you create that trust with that older person and explain what they're going through and offer therapy. So to answer your question, I do not recommend medications right away, but like a talk therapy or something.
Tell me how you got into this field. What made it attractive for you?
So I did my family medicine residency, and before that I was doing some research at Veterans Affairs Hospital in DC. That was in geriatrics. And when I was doing my residency, I came across this question all the time when I was not able to answer questions which older adults were asking, and I got really good explanations from my attendings who are specializing in geriatrics rather than adult attendings. So I kind of had their guidance, like what should I do to learn more about this atypical presentations and how can I enhance my my knowledge. So they told me, like, there's an existing fellowship which you can go for.
It's a growing field. We have more older people than ever. People are living longer.
That's right.
What accounts for that? Certainly medicine is better. Why do we see people living well beyond 100?
So, yeah, I mean, we see more and more older folks living by themselves or in nursing homes. I think it's, as you said, the cutting-edge healthcare system, state-of-the-art medical facilities, and I think we are screening diseases way earlier than we were doing a century ago. So we are able to detect prostate cancer, we are able to detect colon cancer now. There's a screening procedures for dementia now. I mean, you're able to do things. Though you don't have any specific therapy for dementia, but what I mean to say is you are able to detect problems way before than they were happening a century ago.
Here's an email question from Anne. My mom is having memory difficulties. She's 89. What tests should be run to diagnose her condition?
Excellent. So not every memory problems are dementia. I think there's several kinds of testing. So the first test I would start is if this person is depressed or not, because depression and dementia kind of overlap. Then there are some blood tests to rule out other causes of dementia, like B12 deficiency, thyroid disorders. Maybe you have diabetes, which is affecting your brain. So all these kind of things should be looked into. Then there's something called as mini-mental status examination, which is a questionnaire. You ask a patient different kind of questions, and you come up with a score. And there's third type of testing which we do to look at the brain is MRI or CT scan.
Well, in treating an older population, do the treatment goals differ? In other words, a younger person wants to get back to playing sports. Do older folks ever surprise you with what they want out of a doctor's appointment?
Right. So it's important how you ask that question, because everybody would like to achieve something out of that particular intervention, but it's almost about shared decision making. What are their goals? What they really want from that particular intervention? And I always look at if there's a problem, intervention, and outcome, and some older adults have already decided even if they find a mass after colonoscopy, they're not going to operate on it. They're absolutely not. So why to go for colonoscopy? And that's a decision-making, shared decision-making or informed decision-making which you have with your patients.
You sound like a good listener. How can people find somebody who listens really well?
You can go online and look for universities where you can find practicing geriatricians in your community.
Let's take a phone call. This is from Wycomico County. Shirley, thanks for calling. Go ahead.
Yes, sir. I'm calling about, several things. Incidentally, what does Medicare pay as far as if a person has to go into a nursing home, with dementia or Alzheimer's?
Shirley, glad you called. Thanks very much. I don't know how much you know the financial side, but certainly the medical side about when to make those decisions to some sort of continuum of care kind of operation.
So fortunately and unfortunately, patients think we doctors know everything about financial part. But to answer Shirley's question, Medicare does not pay for long-term care side of placement. Medicare only pays for the skilled side. So they have some payment system set up for first 3 weeks, then 100 days and beyond that.
You mentioned the difficulty people have with sleeping increasingly. What's the reason for it? I mean, I suppose it could be, you talk about somebody taking 6 different medicines, it could be in there. Isn't there an organic cause?
So it's very simple, but like in anybody who's born, when they're born, they sleep a lot.
They sure do.
And they cry a lot, and they eat. The first thing, they cry and they start feeding, and they sleep a lot. So if you look at the overall spectrum of the disease, they're developing and now they're declining. So that's the most organic cause. And if you sprinkle salts of medications, sprinkle salts of disease processes like dementia, depression, this problem can go exponentially higher.
Are there differences in how medications work in different populations? I know sometimes different conditions can present differently in a pediatric population and adult population. Is it the same with either presentation or treatment in geriatric cases?
So there's a saying in geriatrics which is called as start low, go slow. So you start with the lowest dose possible and titrate gradually up, because if you don't want to do like a very high dose right away. Older adults, of course, like pediatric population, they're prone to having severe side effect if you just throw them with a high medication dosing. So,
interesting. Let's get one more call. Prince George's County, this is Carmen. Carmen, thank you for calling. Go ahead.
Yes, Dr. Leslie Norris recently did an NPR interview about a germ theory related to Alzheimer's. Do you have any information on that?
Carmen, thank you. Not an Alzheimer's researcher, but your thoughts?
There have been some studies coming out on Alzheimer's. Unfortunately, I came across this name, but I'm sorry, I won't be able to answer that question.
Other basic advice for people in the few seconds we have left in terms of dealing with older people and their issues. How can family members best help?
So I think it's very important to have family members know about their loved ones' wishes, how they want to have their end of like last few years of their life. So appointing a healthcare agent becomes very, very pertinent. I would recommend people who can make decisions for their lives right now should talk to their daughters, sons, spouses about healthcare agent living will.
Very good. We'll leave it there. Dr. Bhatnagar of the University of Maryland, Baltimore, Washington Medical Center. Sir, thank you. Thank you for joining us for Direct Connection. We're back Thursday on MPT. Have a good night.
Your health segments are a co-production of Maryland Public Television and the University of Maryland Medical System.
This program was made by MPT to serve all of our diverse communities.